Okay, everybody. We be back with Waffles in tow, who's just off screen licking a bone, and we're hoping it keeps her entertained. How's Cola Kitty? How are you?
She's in the litter box right now, which
Oh,
is like annoying, but she's good. She likes being outside now on the balcony. She gets really upset if I like have to bring her in. Like she's like a toddler. Like she meows at me and like I think when she goes out there, she like says thank you. Like she just keeps talking to me when she's out there, and I'm like, "You're welcome, but we need to come back inside because there's spiders."
because you actually legit have spiders.
I have legit spiders. One that I think I said this last time. The amount I've learned about spiders in my like ADHD fear of it being like a brown widow is insane. Like I learned about a golden orb weaver. Like who would have thunk that that's a thing? But I have a golden orb weaver on my
They're
balcony. We've
pretty.
become friends.
Yes.
Mm-hmm.
We used to get them in Columbia all the time. Well, Waffles got new AAC buttons this week, so we've been running around the house programming new buttons, and
She's been running around the house and pressing them.
she's been running around the house and pressing them. But Christian put, because we obviously love Futurama, like obviously a huge deal. But there's Bender has this line in it when he's like ready for everybody to get together. He's like, "Let's go already!" So Christian put that in our bedroom at 5:32 in the morning when she wakes up. She shouts out, "Let's go already!" Yes, that's Waffles. Okay, Waffles needs to go away, guys. All right, mommy's calling, not it. But But oh my God, it was the first day of school today. I did not ugly cry dropping off Bear for the first day of elementary school. But there was a mom driving away who was like straight up bawling at drop off, and
Nice.
Bear made eye contact with me in the rear view mirror, and he was like, "Don't cry, Mom." I was like, "Okay." But I didn't. And Goose is thriving, 7th grade. He got engineering and guitars, 2 electives. I'm elated.
Okay. Love that.
So, yeah, totally works. But yeah, it's been a busy week. So everybody, I wish you well for back to school routines in your household.
Yeah. For those of you in New York, where I'm from, you don't have anything for a month or so. So it still
Oh,
blows my mind. Like everybody's like, we're going back to school. And I'm like, oh, yeah, that's crazy.
oh, I didn't know they started so late.
No, in New York, we didn't. Our beginning of summer was like the last week of June, and we would go back after Labor Day every year.
Ah,
Yeah.
interesting.
Mm-hmm.
Well, no, I'm enjoying the schedule. We don't have to pay for summer camps as long. So yes. Okay. Well, we have folks, okay, so some big world news updates. Medicare did reverse their statements, and they're now allowing CFs to bill, and they're approving CFs. So this is a huge step. So again, to everybody who advocated, thank you. Your voices were heard. There's more things. Y'all can pop on ASHA Advocacy. It's through the ASHA PAC, and you can advocate for a whole host of other resources. They're looking at 2026 potential rate cuts. So I would recommend, if you are so inclined, to please go and continue advocating. They make it the simplest process in the world. You put in your address, you put in your name, and it autopilots directly to your representatives. You can customize the pre-populated letter if you would like, or go with what they've got and hit send. Also, are you going to ASHA this year?
Mm-hmm.
I haven't decided if I'm going. So,
I'm presenting.
how many are you presenting?
I just submitted one for AAC and feeding with Amy Zembrisky, who I
Yes.
love. So we're going to talk about like access and how to utilize AAC from like a feeding perspective, which I'm excited because last year I had 4. So we're just going to do one and just, enjoy, but it's in DC. I'm very excited. We're trying to get Michelle to come. It's also very close to you. So
I know. Serving as topic chair for 2 years was a lot. And it's emotionally exhausting. And I'm also, the social anxiety is legit, and that gets worse the older I get. So yeah, we'll wrap it in prayer and see what comes out. How
We'll
about that?
see what happens. Yeah.
Ah, okay. Well, I'm excited to see the PFD and AAC talk. I you make me want to go because I just want to see you present, because that'll be a good talk. So we'll think. We'll
I
think.
think, yeah, there's lots of stuff coming up. Yeah, if you haven't, I'm doing a free presentation for the Child Led Autism Summit that is my presentation is the 20th, but it's like the 18th to the 20th, and there's like
Of
25
August,
of August. So
and it's all virtual.
it's all virtual and it's free unless you want some of like the extra stuff, but
Okay.
all free, which is really awesome. So
Nice. Okay.
check that out. And the Floor Time Conference is in October, so check that out. I've got just things coming up. I'm exhausted, so but it's great.
Nice. I've got I'm presenting a 3-hour course for Mississippi on Friday, September 19th, on understanding medical etiologies and PFD for autistic individuals, but
Is that
transitioning
in
it toward,
person?
pardon?
Is that in person?
Yes, ma'am. But focusing it on like a social model. So understanding we have to address the medical etiologies, but doing it in a person first way, but also the advocacy piece of this, because which segues beautifully into our talk today. But I'm so frustrated with um, it, an autistic child getting slushed off to, oh, well, that's just their autism, without doing any diagnostics or any supports to actually understand what could be going on with the tiny human. That's just been really frustrating lately.
Yeah.
So, but yeah, okay. So, folks, Erin and I sat back and we were looking on like topics that we'd covered lately and topics that we hadn't talked about. And we felt it was time just to do a good old fashioned pediatric feeding disorder case study. Because her and I both learn through case studies. Like, we troubleshoot literally all the time. Because we grow from one another, right? Or we call our sweet friend Melissa and troubleshoot cases with her. But uh, the we kind of have a couple different ones to talk about, and this is a good teaser for on Friday, August 22nd. Feeding Matters has the psychology of eating summit available, and that's going to be a spectacular talk. And it's very holistic. But I have had some kids come to me for PFD. When we get down to it, it's actually ARFID. And unfortunately, we can't find counselors nearby where I live that are skilled to support this. So that's kind of we could start there. Um, how about
Yeah.
Go ahead.
And I think that the conversation with PFD and ARFID is so tricky because a lot of kids, like, it used to be Feeding Matters said that if you have a PFD diagnosis or underlying medical etiology, it's not ARFID because you have that medical piece. Because of the advocacy in the ARFID community and the advocacy in the PFD community, there have been a lot more conversations about the overlap between the two and how it can overlap. And I think it I struggle sometimes of the, like, do we want to advocate for the ARFID diagnosis or not? Because sometimes I think if there's an ARFID diagnosis, there's not a push to dig deeper for medical. But sometimes if there's an ARFID diagnosis, it helps have better understanding that there is an anxiety piece to it. I had a mom the other day who her child is not diagnosed, but she believes is autistic. I do as well. The father is not quite there yet. And I had explained to her and gave her the advocacy for like what a pediatric feeding disorder is. And she said to a family member, like, he'll only drink out of one sippy cup, right? And very common. We see all the time with our autistic kids. And she doesn't push him. She's offering another cup. We're trying to expand. And she said, she said to somebody in the family, like, he's not just going to eat when he's hungry. Like, he has a pediatric feeding disorder. Like, his speech therapist told me about it. And someone said, well, that's just a diagnosis for like when people don't know what to do. Which is just we're learning, and this mom is amazing and she's advocating. But I think it's the conversations that I've been having recently, and like you and I have been having, is we have to be so patient and family specific with our recommendations. And that can be really tricky, especially as a new grad, because you want to have the answers. And I've had so many conversations recently about like, I don't know I'm never going to be able to tell you what to do for a child unless I meet and understand that child. Like, I can give you resources, I can give you ideas, I can give you some recommendations, but most of the information that you need is in front of you. And we get a little in our head with like protocols and strategies and this and that, and try to fit these kids into a box when they don't fit into a box. And because we're in our safe space on the podcast, if you are just following a protocol, that is not very skilled. I can teach anybody to follow a protocol. When you can take a protocol or a strategy or a treatment idea and adjust it for the child and the family in front of you, that is the skilled part. And that takes time, and I completely understand that. But that's kind of what we're here to talk about today and problem solve through, because that is the hardest part, but that's the most important part.
Yeah. So I am brand new to a kid who I've got a brand new little guy that I'm working with who we have anxiety and trauma in home. Couple of ACEs, folks, ACEs, adverse childhood events. So situations like divorced caregivers, new family members, split homes. So there's different rules at different homes. Mom actually is a counselor herself, and is trauma informed, which is so novel to work with a therapist that helps with pediatric trauma. Like, that is just really cool for me because I don't have to code switch or define as much. Like, I can get a little more, like, I don't know, it's just really cool. And the sweet Bubby, one of the first things that, we did was, all right, well, what is your anxiety? Like, what does caregiver anxiety look like? What does child's anxiety look like? And folks, some states, because insurance is starting to tighten the belt because of the one big bastard of a bill that was passed last month, you might need functional resources to justify the psychosocial domain. Remember, pediatric feeding disorder, we have the medical, nutrition, feeding skill, and the psychosocial domain. But I would suggest, and these are kind of similar questions that I asked, if you check out the Feeding Flock, they have two tools or prompts, as Dr. Goza and Dr. Marshall would describe. But they have the impact of feeding on parent and family scales. It's the feeding impact scales for birth to 3. And then they have another, a family management measure of feeding, or the FAM feed. And so one kind of understands how this feeding disorder is impacting all of this, and the other one is like, how are they managing it? But those two tools are free. They have been researched, and you can take them as baselines and then take them as like ongoing measurements to understand how the psychosocial domain is progressing. But those are great free evidence-based resources that you can incorporate into your practice to understand that domain that is not necessarily our scope of practice, but we still have to be able to quantify, especially if we're trying to get in for ARFID, right? Um, or get referrals over or justify over, especially in my neck of the woods. But this little guy, when we started out, one of the most interesting things that I noticed was there seemed to be some underlying vision component. How he's holding his food or interacting with food struck me as if he's trying to find a null point, NULL. And so the first thing we did was talk about, like, all right, how's his vision in class and reading? And it turns out he struggles with going from board to desk and back up. And there's all of these other factors, but it's subtle. And I'm kind of curious because vision impacts feeding skill and a child's relationship with food. And we're getting him to an eye doctor. And I'm more acutely aware of this because we had a little guy that I've worked with for months and we knew he was kind of klutzy. And, we talked about seeing an eye doctor, but he was just 3 and kind of klutzy. Bless if that child didn't come back with a -6 in each eye, and mom's nurse, all of us, we had no idea he couldn't see that poorly because he didn't ever look like he was trying to find a null point, and all of a sudden he's seeing and now he's exploring with food more. So you live and you learn. So now I'm like super vigilante for, like, okay, how is your heart doing with your child's eating? And oh, by the way, when was the last time they had their vision checked? Which, yeah. So hi.
Yeah, I mean, I think, and like we said, we were going to kind of bring up some different case studies today. I had a conversation with one of the students in my cohort this week about a case that she had that like had all these complexities, and I feel like it can get really overwhelming when you like look at a case history and you're like, wow, there's so many things, or there's so many diagnoses, or there's so much history,
Yes.
and it can be hard to know where to start.
Yes.
um Especially when you have, and the cases Michelle and I end up with are usually there's significant medical complexities, but there's also trauma and a lot of social situation or like psychosocial components in regard to the feeding, which is like pretty common if you're going to have some of the medical stuff. But I had a I'm trying to think of which case I want to start with. For example, well, I'll talk about this one that I just started with. We'll start with an infant because this one was pretty interesting and we don't quite have all the information yet. But we'll start with the classic, they have a tongue tie. And also, again, all of these things like family history, family culture, looking at that full picture is really important. And so I just started seeing this infant, a couple months old. Mom was like, dentist said they need their tongue clipped. Like they need their tongue clipped. I'm breastfeeding. Breastfeeding is a little painful. The latch is really shallow. I'm not really sure about it because he's gaining weight really well and it's not that uncomfortable. So let's assess that. So I go in, we're having trouble with bottle too. Like we're refusing bottle. So, okay, let's go in. Let's see what's going on. Great attachment to mom, great relationship to mom, had been in the NICU for a couple weeks. So there's a relationship component to that. And when I'm watching breastfeeding, like we definitely have a shallow latch, like more nipple than breastfeeding. But as I'm asking more questions too, I like noticed we had a moment of coughing, which I just noted. And then mom brings up something about snoring. And I was like, okay, super interesting. Super interesting. We know babies shouldn't snore. So I'm talking to mom and I'm like, I'm curious, like, has this child seen ENT? And she's like, no, he hasn't seen ENT, but I've really been wanting him to see ENT because of history. Like, all my other kids saw ENT, whatever. And as I'm watching the baby breastfeed too, I'm like, I'm just wondering, like, for a lot of kids, they have a more of an open or shallow latch if it's hard to breathe through their nose. They're snoring and they have adenoids, tonsils, things like that. It can be harder for them to breathe through their nose. They might want to keep their mouth open a little bit more so that they can breathe while they're eating. I don't know, but and I like to not, obviously, I'm not going to diagnose anything, but when I'm doing an evaluation, and this caregiver had some medical background. So I could, again, speak with some like more language that she understood. Um, but I want the caregiver to understand like where my head is at. And I think that's something that like newer clinicians are afraid to say, which is totally understandable. But the more you can help them understand what you're thinking and what you're problem solving within reason of like what their health literacy is, the more they trust you because you're being um honest and upfront too. Like, I'm not going to sit there and be like, I have all the answers, but these are where my brain is these are some differentials that we have, which is something physicians will do as well, like not to scare them in certain areas. But um and she was like, oh, that does make a lot of sense. I was like, again, I don't know, but I'm not going to jump to clipping a tongue if you aren't that uncomfortable. And it's also, he's a little bit older. So, like, we're going to have to relearn if we clip their tongue as well. And I want to also understand, regardless if a tongue tie is something of concern, what's going on with your airway. So there's all these factors as well. But then there's another factor of like attachment, because bottle feeding is really, he doesn't really love to take a bottle. And so like you have a kid who was in the NICU, you have a kid who there's like lots of stuff going on in the home. You have a kid who caregiver worked so hard to do breastfeeding and go for all the cares in the NICU. And so like this is this beautiful interaction, but like, yes, mom wants to be able to have him feed a bottle. So I'm starting with like, this is beautiful. This is wonderful. Like the fact that he's so successful with breastfeeding is amazing, but I totally understand why you want to go to bottle. But it's not just the oral motor piece of it. There's an attachment piece of it. So like even with an infant, there is a psychosocial component to what's happening, and we forget about that, and we have to remember to like acknowledge and say how, because it's easy to go with, well, bottle feeding isn't working. And I totally get that this caregiver wants to be the ball, but also let's acknowledge how amazing it is that you've been breastfeeding him when like he was in the NICU and you're having such success with that, because that's a testament to all of this. And I don't have any of the answers. This is just like eval. This is what I'm thinking. And that's
Let's do
okay.
referrals. Yes.
Yeah.
Okay. So one, I just finished, and y'all, thank you for being patient with me. Erin, thank you with my whole heart for being patient with me this summer, because I just finished teaching the class for North Carolina Central University for their PFD class. And the students, this year, I gave an assignment to administer proms on each other. And some of the proms available on Feeding Flock, they actually have one designed for like infants, like post NICU, or like little bitty guys. And that was exciting to me to hear how, one, the students were practicing it and getting comfortable with it. But that's another tool that we have available for free in our arsenal, so that if we're starting out and we need guidance on like, hey, where do I begin? How do I find out caregiver comfortability with feeding if you've never had a graduate class in pediatric feeding and swallowing disorders? Like, how do I measure what their anxiety level looks like and how it's impacting attunement and attachment? We have those resources. Okay, so to piggyback on your eval, I have a little one that I've seen for an eval. And it's only once a month for treatment, because honestly, I don't think that I am the it. And I'm going, I am very candid with families when I don't think you need like aggressive intervention, but we need interprofessional practice. So, case study, 15-month-old comes to me. Oh my God, she's so cute. She has the cutest little bows in her hair. And like, I'm getting all these little girls that have these bows that are like, makes me want my uterus back. But a caregiver shared that they had tongue tied and lip tied both done twice because they tethered back afterwards, right? They had difficulty with breastfeeding, transition to bottles, um, started gaining weight, but complaint now or earlier this summer, but they had to sit on the wait list because I don't have so many openings. Was that signs and symptoms of aspiration penetration with thin liquids, right? So I'm watching her play, I'm watching her breathe, and my first concern is laryngomalacia, trachomalacia, bronchomalacia. What's going on with their airway? Or is there an undiagnosed laryngeal cleft? Excuse me, hiccup. But also kind of a klutzy child, another klutzy, kind of like lower tone child. But again, 15 months old, they're squishy little marshmallow puff kids at that stage of the game. And it is what it is. Well, mom's actually an allied health member. So she's got some keen insight into gross motor, fine motor skill sets. Did the eval, gave the recommendation, follow up with ENT. ENT results, we had no signs and symptoms of laryngomalacia, trachomalacia. Can't rule out a laryngeal cleft because it was an in-office nasoendoscopy. But did recommend a swallow study. I saw clinically no overt signs and symptoms of aspiration penetration during clinical eval. Managing secretions, nothing that, I didn't think modified was indicated at that time. ENT, after they scoped, did find adenoid occlusion of 30%, but nothing else, and said, look, the next step is an instrumental swallow eval if you would like. And if that yields anything, then we'll go look for a laryngeal cleft. Came back for their follow up. And again, I'm only seeing them once a month because here's the catch, folks. At this stage of the game, I'm not bringing anything to the table, right? Honestly, like I gave recommendation for changing the volume of the cup. We had big cup, trying to open mouth drink. I recommended red solo shot glass size. Family comes back and says, well, we want to play with it, but we're drinking it when we do drink it and don't dump it. And I'm like, okay, valid. Gravity is God's greatest gift to humanity and an awesome, fun game. So she likes to dump it everywhere, right? But we're drinking from a different straw cup because I recommended the little one that you can like flip over. It has the weighted straw, cut the straw down so we're not pushing it too far posteriorly to increase premature spillage. High cola. And with those changes and just her overall growth, gross motor wise, in the last month, it has so dramatically improved. And so I started probing more. What did she look like 5 months ago when you requested this? Like, what did we look like from a tone issue 5 months ago? Because extrinsic laryngeal musculature impacts intrinsic laryngeal musculature. And if we're low tone and flappy, then it would make sense that she struggled more with hyolaryngeal excursion to actually open up the laryngeal vestibule, to open up her cricosophageal sphincter, to move the bolus through more. And they were like, she was not as mobile and a little more klutzy, and it's improved. Now, we're touching base again in a month. I gave them some additional strategies to make, cup drinking more fun, and, we'll just touch base. But like, we all kind of walked away with, we're doing great. Keep doing the strategies that you've implemented. If there's a change, call back. But what was cool to me was that we got into ENT so quickly. The ENT seeing exactly what I saw, the risk for laryngeal cleft. And I just loved how in sync the whole process was for the caregivers. But what was asked was, do you think getting the tongue and lip tie? And I was like, look, I can't talk about something when I wasn't there.
Mm-hmm.
And that was a tricksy question that I would love for all colleagues to know. If you weren't there, we can't answer that question. We don't know what it was like. I don't know what kind of impact it will have or could have had. I just know what the tissue looks like now, and we look healthy. But man, what a neat case, and I'm excited to see how we look in a month after more practice just drinking from a cup that fits our volume and our size.
Mm-hmm.
Yeah.
Yeah, I think and you and I are similar in this way where like, if I don't feel like what I'm doing is like bringing a new skill, or like if I feel like a kid's just coming in for me to like observe their progress on the exact same plan, I don't feel like it's super skilled. And I know that can be challenging depending on what setting you're in and what's happening. But thinking about like where that, this is when thinking about where that caregiver is very helpful. Like I have discharged children sooner than they've met their goals because I feel confident and the caregivers feels confident that they can continue to progress them, because children are also always developing. So if that caregiver knows how to introduce the food, they're progressing, they know what to watch out for, their skills are doing well, just because they haven't quite gotten, even if they're, even my to be babies, like even if we haven't fully like reached full PO, but that caregiver feels comfortable and confident and I'm still here as a resource and they can always come back. I have said, like, if you're comfortable, I think I'm totally comfortable. I talk with the medical team, see what their thoughts are, because also the medical team sometimes thinks we're magic and like we can just fix all of the things and like get the kid to eat food, when like volume is something that like is really difficult for us to fix, because that's really, really intrinsically what that child is comfortable with. And so if volume is an issue, that's when I'm like problem solving with caregiver and registered dietitian of like, what foods can we give them that are easier for them to eat, or this and that. And so making sure that you're constantly having those conversations of like, what is the caregiver comfortable with? How do they feel about this? Is this something that's really important? And that should be a big part of your plan of care, because it we over therapize kids a lot.
Yes.
And also, the longer you therapize a kid, the less confident the caregiver often feels,
Yes.
because they're like, well, you've been doing this for so long, or you're the only one that can do this. Like, I don't feel comfortable doing this. And so
Yes.
I also rarely feed a child.
Yep.
The caregiver is feeding them or they're feeding themselves. The only time I do that is if I'm like trying to feel something or try something out, or like, especially with an infant, I'm like, can I just feel their sucker? Can I just like see what's going on? But like, my job is not for me to feed that child. My job is for that caregiver or that child to feed themselves. And so I want people to start to think more about that. When I did my floor time training, and I took my course in like caregiver coaching, the thing that was so interesting was because like people would show videos and they'd be like, we aren't, the caregiver may not be able to get that kid to the same capacity that you are able to get them as a skilled clinician. But the important part is for you to help that caregiver get them to the capacity that the caregiver is capable of getting them to. And I think that's something that we also have to think about. Like, you may be able to do something really beautifully because you've been feeding, all you do is feed kids, but I'd rather the caregiver have the experience of getting that child somewhere with me that maybe isn't as fast as I could have done it on my own, because that attachment relationship piece is so important. And so those constant check-in with caregivers are also helpful. And what I will say from like a trauma informed ARFID standpoint, and where I get really tested.
Your eyebrow wiggle gave it away, love.
My client yesterday was like going like this, and I was like, what are you doing? She goes, just stretching my eyebrows, look how long they are. And I was like, sure. A lot of times caregivers are making decisions to clip a tongue tie out of fear. And I don't want any caregiver in my presence to be making a decision out of fear. I want them to be making a decision out of knowledge, out of understanding. And so, if we also think about it that way, our first job in working with a family is to reduce their sense of urgency. Like Dr. Jillian Bordeaux always says, that's like we did a podcast with her. I recommend going to listen to it. Reduce the sense of urgency so they feel comfortable to make decisions from their whole brain. Because most of the caregivers that are in our sessions and the kids that are in our sessions are making decisions from their lower brain. And any language,
Reactive as opposed to proactive.
yes. And
Fear,
so,
yes.
yes. And so spend time helping them understand. Like I had a family the other day that the registered dietitian brought up feeding tube. They ended up going to the appointment. He had gained more weight than we expected and he's doing really well. Like he's progressing. So I'm confident with this, but I was not sure. And I sat mom down and we spent half a session just talking about a feeding tube because the registered dietitian had brought it up and mom like didn't really understand. And so I was like, I want you to ask me any questions. I want you to feel seen. I want you to feel heard. I want you to feel, because the scary part is the unknown. And so thinking about how do I get this family to feel less anxious, less traumatized by this experience of food and whatever that needs to be. And sometimes that's just like, let me explain to you why this kid's doing what they're doing. Let me explain to you why I think that this is happening. Ooh, did you see when he kind of made that face, or like you saw him kind of take a deep breath? Like that may be giving me information that like this is too much, and that's okay. Like I completely understand why that's happening. And what I will do with infants and even older kids is like I'll model in a way that's not directly towards the caregiver. Be like with an infant, I'm like, oh, that was a little too fast for you, wasn't it? I can see your eyebrows go up. Or oh, with a kid, like, oh, sometimes that makes me nervous when I have a new food too. Like you're giving language to what they're thinking, especially with our autistic kids and like our non-speaking autistic kids, like giving meaning to them looking over at something or giving meaning to the little cues that they're doing. The more that caregiver understands, the less scary all of these things become, because they get their kid. And then when someone asks them, oh, why is your kid not doing this? They can say, because it's overwhelming for them, or because this. And the more they can explain to other people and understand their kid, the less scary it is. The scary is I don't know why my kid's doing this, and no one's been able to tell me why my kid's doing this, and I'm scared that they're not going to get their nutrition. I'm scared that somebody's going to make fun of them or whatever. If that makes sense. I just rambled.
No, it's so much sense. But you said a couple things that I want to highlight. You and I consistently go back to the conversations we're having with the caregivers. So, folks, just for clarification, when we do therapy, the caregivers are present the duration of the session. We are clinicians and not magicians, although I do have copious amounts of bubble wands and I still think bubbles are magical. But honest to goodness, I am only as good as my caregiver feels empowered, right?
And
And
don't talk about the kid like they're not there.
yeah, they're listening 1,000. Oh, that's a soapbox for another day, and I will come
So
back to that.
we can't. If I'm having a conversation about a child and the food, I don't care where their language is. Like
They're
I'm
absorbing
either
it
part of the
completely.
conversation,
Yep.
or I'm calling the caregiver afterwards and talking about it
Yes.
after.
Yes. But one of the things that our job as allied health members is to put ourselves out of a job. I don't want that child with me for extended periods of time. My job is to get in, eval, support, empower, and educate the caregiver so that they can successfully implement and identify and implement strategies in their natural environment, right? Because we only get them for those brief periods of time. So, step one, please go and take a peek at fgrbi.com, Family Guided Routines Based Intervention. That is an amazing resource for how to engage in caregiver coaching. Two, take a peek at episodic care. Sometimes by simply switching over to 1 time a week times 3 months, pause for 3 months, it puts it gives a definitive structure that, like, look, we're only doing this for 3 months, and then y'all take this and run with it for 3 months, and then come back to me the following 3 months, and let's talk about how successful was this, right? And that doesn't work for everybody. I'll completely acknowledge that. But for some kids, it works great. But I had a mom come to me today, and it has taken, like, we had the little ones reeval, changing from the clinic because uh, the full disclosure, folks, the clinic that I was working at, the owner, her husband became deathly ill, and so they closed. Spinal surgeries are terrifying and catastrophic. So I transitioned because the clinic was closing over to Albemarle Therapy Center, and God, freaking amazing team. I work with some dynamic OTs and SLPs, but I had to do a reeval on a child because we were right at like that 6 month timeline and need new information. Then, good Lord, the state Medicaid is taking forever and a day. So it was almost 6 weeks to get the prior auth approved because that's how far we're already seeing impact on prior auth in Virginia with certain Medicaids. So we came back in and we're touching base on all of these updates, and caregiver was telling me, Bubby's 10 years old, walks in wearing a shirt that says I like hot moms, and I burst out, lost my marbles. And the mom was like, yeah, he thought you'd get a kick out of this. So it's like, that's amazing. So yes, but said the pediatrician told her, we have a hyperactive gag reflex, maybe your speech therapist could fix this. Okay, in all of my academic and additional continuing ed, not once have I taken a class on how to fix a gag reflex. But then that terrifies me because is that what pediatricians really think that I do? Is I shove things in kids' faces to fix a
Either give
gag?
back their gag or you take it away.
Yeah, and I'm like, no, that's, and so of course, mom knows me, and it turned into a big joke. But like, anyways, this is a complex case that on the surface looks typical, which leads back to a conversation that I had with another colleague earlier today about how, especially for our neurospicy friends, they may look typical, especially when we have low support needs. But Bubby's underlying medical needs had been dismissed for so long, and the fear of food was so profound because food made us sick. So over the last couple of months, while we're waiting on, like, we finally have our upcoming GI appointment with like comprehensive allergy testing and like the whole 9 yards, the caregiver has started eliminating certain foods that were high fat that she correlated to both of them getting violently ill on. And one of the big ones was eliminating beef. And once they eliminated beef for this child, and some other certain processed foods, the pain right here from the gallbladder site, which happens if you have like high fat foods, like I've had my gallbladder out, like biliary dyskinesia runs within indigenous tribes, which is a data point for the specific case, past medical history. Elimination of those foods, he started feeling better. And then we just empower the caregiver to, yes, we did do a modified version of Touch It, Kiss It, Lick It, SOS, but I call it the five senses. That's just what I call it, where we like listen to it and then smell it, like consolidate it down just to your five senses, which most kids know because they study the five senses in elementary school. And mom came in today and she was like, Michelle, he's trying like everything. He's not afraid. He snatches it off my plate, snatches it off of Sissy's plate. Like, we're trying all the foods, have added new foods. I was so happy. I was like, I'm going to start crying because that's what I do when I'm really happy, is I have big old fat teardrops roll down my face. But his confidence naturally improved because he started feeling better because they took the steps to get him in that direction. And pediatricians supported this, all because I wrote a really comprehensive evaluation. The power of a thorough pediatric feeding disorder eval that breaks it down according to the 4 domains, the signs and symptoms within, and it it started there, and then constant education. And I go back to, I'm going to shamelessly plug Feeding Matters conference on the 22nd, because this is the psychology of eating I want these caregivers to go to, and it's only $25 for the caregivers. And I'm like, look, we don't have a counselor. We need to get a counselor on board, but I think this is a missing piece of the puzzle, to kind of help get us where we need to be in the end. In the next, and I'm phasing out here in the next 4 to 6 weeks, is let's just make sure that y'all have those supports. Um, but our strategy for intervention for the month was, because, homeschool, we don't have like school lunch menus. But I got inspired because Bear wants to eat school lunch this year, which has like never really happened. I'm getting thumbs up in the background. It's he wants to explore school lunches, but we went through the menu, and what I saw was that there's a repetitive pattern where certain foods are offered 3 times, not more than 4, but 3 times throughout the month. And I mentioned that. I was like, this would be a great opportunity. She goes, oh, we could get that 14 and 21 in, because we talked about 14 exposures or experience within 21 days so that it becomes regular, and something predictable. So their homework for the week, their strategy is to make their own menu for the month of August for homeschool, for lunches. And he was so excited about this. I don't know. It was just, good Lord. It was a great therapy day today. And yesterday was a heavy therapy day, but like today was a great therapy day. But it's one of those cases that on the surface was dismissed because we look typical. But when we dug deeper, because of a comprehensive eval, we're having all of the findings and getting the interventions. Oh, by the way, we got glasses. Oh, by the way, we had a sleep study with apneic periods. Oh, by the way, blah, 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 blah. But like,
Mm-hmm.
it's just awe inspiring to see such strong caregivers take such bold leaps.
Yeah.
Yeah.
And we also have to remember, and this is why like I talk about mealtime literacy, because our clients and kids' understanding of mealtime is vastly different than like we may think. And so
And it
in
looks different for everybody.
Well, it's different for everybody. And so a lot of the work that happens in therapy and what we can help caregivers understand is like ways to help that food feel safe, or ways to identify foods that may be more safe for them. Um, which is incredibly individualized. There's a lot of value to like reading books about food, or like I had a kid today who he's more of an overall anxious kid. And this is the thing with ARFID too, is like you oftentimes see where like overall there's anxiety and then it's manifesting within the context of food, whether it be because of a negative experience or something. We're just going to be more sensitive. And I have this conversation all the time with caregivers where like, remember when I worked in the hospital, kids would have like an NG tube and doctors would be like, well, it shouldn't really bother them. Like it's, it's not that big of a deal or whatever. Or reflux is a good example. Like for some kids, they don't care, right? Like I spit up, whatever. Some kids, it really affects them. And so
Their
my
threshold is
push,
higher
yes, my push
or
for
lower.
having conversations with doctors and, advocating for certain things is very dependent on that, how that child is feeling about it and how it's impacting their feeding, just function, like very similar. And so, you know, this little boy who's a little more anxious overall, and then had this like, was kind of starting to get picky with food, didn't have support from pediatrician. It's going to be fine. He'll grow out of it. He'll grow out of it. He'll grow out of it. Eventually, we really liked a lot of meat, had a hospital stay, from going into ketosis. So like we didn't have the support. We had this negative experience. It was not the family's fault. They were amazing. They were doing everything that they could. They weren't provided with the resources and support that help. So there's a lot of anxiety around food. We're doing really well. We went to New York, or we went on a trip, and we tried spaghetti. We liked it. We were on a trip. It was new. A lot of kids will like try new things when like the whole environment is. Mom made macaroni instead of spaghetti. And she's like, it's this, but it's the same thing. We kept telling it was the same thing. And I was like, for you and I, we have this bridge of pasta is the same thing. But even though it's the same color, it's the same texture, it's a completely different shape. And to him, that's just like, whoa, this is too much. And so what did we spend time doing in the session? Looking up different pictures of pasta. We
Yes.
watched a video of how pasta is made, how they cut different shapes into it. We like work to understand what he was actually eating, and within the context of like his knowledge and his cognition and his social emotional capacities, which is like nothing different than when I have a child who his main play schema is throwing food, and I give him a new, or throwing toys, and when we try new food he throws it. Like I have another little boy I'm working with who I've been seeing him for months, and it took us a long time to get to like engagement. I'm here with you. We're like back and forth. And I'm like, okay, mom, I think now is time for feeding. I think we can start to address feeding because we're finally like, I'm with you. I can get some good engagement. Like that's when we're there. And so I opened up a snack in the session while we were playing, and like he first threw it, which is like very normal. That's how he learns about something. And the next time he picked it up and like licked it completely on his own. I didn't like, yeah. Then the next week we tried it, and he like started feeding mom, and then he started feeding me. And one of my coworkers from across the room, who's like a little more of a germaphobe, was like, like I could feel her anxiety. I was like, it's fine. It's fine. Your mouth has a lot of like, it'll be fine. It'll neutralize whatever was on his hands. Um, but like he's learning about the food in a way that like works for him. And somebody might look and say like, you didn't do anything. Like you didn't do anything in therapy. And what I would say to that is I knew when he was ready. I picked a food that was in conjunction with like things that he liked. I created a safe space. I set up the environment. I understood how he learned about things. So I followed his lead. I presented food. I like read his cues. All of that was incredibly skilled. But to someone watching, they would say, you opened up a package and he just threw the food. You didn't do anything. That's where I struggle, because some would say you had no intervention there. Where was your intervention? What were you doing? And what I would say to them is the intervention was in all of those other things. And I know that's like my shtick because it makes me so frustrated because people just want like a do this when this happens. And like it doesn't work that way. And when it works, it works. And somebody really pissed me off recently. I will say, Michelle knows about this.
Yes,
I
I do. Oh,
say
good Lord, your Irish showed.
anything, but it really made me pissed off, for lack of a better term, because it was this whole, well, when are you eventually going to make this kid eat? You can't keep playing with them. And like kids are going to manipulate you and say that something is, if a kid is feeling
No.
so anxious that they are trying to not eat the food, you are missing something. And if you know what play actually looks like, and that it doesn't have to be, play is just something that a child initiates that they enjoy. Play could be having a conversation at the table. So yes, I will always be doing play with this child. If you do feeding therapy the right way and for the child, they will eventually do it on their own. And if they're not doing it on their own, they're either not ready or we're missing something. And I am a firm believer in that. And to the person that made me mad, I didn't respond, but that's how I feel.
Yes, because you're a professional
I'm a
and you're
professional, and
kind.
I only say,
Ooh.
only vent to my friends about it.
Waffles thought I was barking at her when I was like, oof. Yes, no, it's good. We're good. Okay, so many thoughts on this. But it goes back to treatment can look glamorous on social media. but your treatment is predicated in your comprehensive eval, in your interprofessional practice and advocacy with the specialist, so that you have ruled out or are in the process of getting the big, bad, ugly, and scary stuff ruled out. And I had one mom tell me today, I think it's all in their head. Um, and I was like, no, honey. I was like, every time we can take it all the way back. There's always a medical etiology.
Yes, always go
Always.
back to the beginning too. Don't forget,
Yes.
like that's like I don't care if they're 11. Like, what did it look like when you did bottle or breast? What did
Yes.
it look like when you
Take
introduced table
all,
food?
all the way back to the beginning, because you will always find it if you have an interprofessional practice team that's willing to take the time. So, my last little one that I wanted to talk about, because it really is about interprofessional practice and how do we advocate. We have to empower the caregivers. So, this sweet little girl I have worked with, and mealtimes look different for every family, right? Um, we're really honest that we have dinner table dinners, and then we have picnic table dinners, and
Mhm.
picnic table dinners tend to happen on the weekends. They have happened a lot less since Ma'am Waffles has joined our family, because she's a lot quicker than Dog was, and picnic table dinners are subject to being devoured by a breakfast food. But this family prefers to eat breakfast, lunch, and dinner consistently at the table. And so she wants therapy to happen at the table, because this is part of their normal routines, right? So I'm going to honor the routines. And this child's neurodivergence, she loves written expectations. She loves, show me what we're going to do and I want to see it, because language is a little abstract and we like the concrete. So today, and mom's doing an amazing job of letting her explore, letting her pick out, we're borrowing Melissa's from store to table. So she picks out her food at the grocery store. So it was a Lunchable. And we've spent all this time working on hot dogs, and I don't eat meat, but there I am throwing down on a hot dog, sleight of hand so I don't die. But she wanted a bologna Lunchable. And all I started doing was giggling in my head, because we one time saw the Oscar Mayer Wiener truck, and I have a picture of me pregnant with Goose and Christian outside the Oscar Mayer Wiener truck. And little girl loves music videos. And I was like, do you know the bologna song? And so mom, who's like only a little younger than me, starts laughing. And we found the original Oscar Mayer bologna video song. And there we are. Her and I are like living our best childhood. And the tiny human is looking at us like we've gone around the bend. And I was like, honey, this is going to go great. So we explored the new crackers, loved the new crackers, explored the new cheese, not feeling the new cheese, tried the bologna, and I was like, let's just try something. So we turned it into smiley faces and then used cheese eyeballs. And then I was like, how about we just bite it with our teeth and then spit it? Because she likes to spit, right? So we bite it and we spit it out. And, she had that second bite and I saw her eyebrows go up and I was like, it tastes like a hot dog, doesn't it? Next thing I know, she spontaneously chewed and swallowed it, which gets me back to my goals. I write my goals so that the child spontaneously bites and chews. I don't want it to be an external, like, you're doing it because I'm making you do it. I may work with you to like have an experience with it. Like, we're going to like touch it, kiss it, lick it. Works for some kids, not everybody. And she likes the structure of some of those aspects. But she, once we got over that initial fear of it and she bit into it and tasted it, it tastes like a hot dog. Bologna tastes like a hot dog. She devoured the bologna. And it was like, and mom was like, yes. And then she goes, okay, I have room for a cookie now. And I was like, yes, you have room for a cookie. And so, I mean, also you get a Lunchable because it has the good desserts. Like, I'm a mom. I know what's up here. But it was just really exciting to see, because when we got done, mom was talking about it. She goes, I still see the fear with her. I see the fear whenever it's something new. So my referral was, let's get you back over to the Feeding Matters conference. And then this is a mom who I have had to advocate to the maximum ability through written documentation and phone calls to get the pediatrician on board with ENT. We have a open mouth gate, an open dental bite. Um, uh, there's significant red flags for an airway obstruction and a family history for hypertrophy of adenoid tissues and tonsillar tissues. And girlfriend has the facial patterns that I would anticipate having enlarged adenoids, which do make it difficult to time out that respiration deglutition, that apneic period, and having a comprehensive exhale after a swallow. So, anyways, mom came by today and she was like, I think they finally made the OT referral, but I don't know about ENT. And I was like, they told me they did. So, caregivers continuing to advocate. But that's an area of trust. We have to establish trust with the caregivers, that they trust our clinical judgment, that they have the self confidence, especially if you're a minority or you're a female, to when you're encountering a older white male physician, to be able to say, no, this is the referral that I want, and to stand firm when the physician may not concur. But I'm going to quote my friend Chantel: pediatricians work for the parents. Like, that's their job, is to be a generalist, to open the doors to get to the specialist. And I mean, some referrals are I mean, I've asked for stuff and I'm like, I think this could be the way. And the pediatrician comes back with, oh no, I really want to send over here. I'm like, all right, I'm just glad we're sending somewhere. But there has to be so much trust in these relationships. But all that goes back to me, to the beginning of, what's the tone that you're setting in your eval? And are you truly engaging in caregiver coaching around their normal routines? Because I wouldn't know how to customize my therapy for this family to make it more structured if I didn't understand this family thrives in structure. You know what I mean?
Mm-hmm.
Especially when I have other ones where we're like squirting whipped cream at each other. So like,
Mm-hmm.
also we now squirt whipped cream in Goose's mouth and then Waffle's mouth, and it's like, we're fine. This is normal. Yeah.
Also, our like, don't forget our autistic kids. There's usually there can oftentimes be medical things going on as well that
Yes.
get really dismissed. So
GI, so much GI,
constipation
so much
is
airway.
not, yeah. Find a
Allergies.
good. I have
So,
a really fantastic GI down here that I love.
who?
Wonderful. Dr. Watley is so great. I referred to him when I was in Greenville. He's so kind. He's just the
Mid-sized
best.
manner.
Yes, and like really takes the time he takes the time to explain why he's doing what he's doing, which is rare for like sometimes for physicians. Like you'll get a lot of they're fine or this or that. Like he really will walk you through it, and he will spend a lot of time with his patients. So I'm very grateful because, you know, especially our non-speaking kids, and like we don't have time, we'll like do a lot, we can have more conversations about that, but like they constipation, stomach aches, headaches, like so
Yes.
many things that we don't know. And if you have what I will say about our non-speaking kids is they will tend, ow, my cat.
I'm sorry, Cola Kitty just bit Erin, and I'm over here with a teething puppy teething on my fingers. So we're like, this is a labor of love.
If Coley made me lose my train of thought. I had a good point.
Our autistic non-speaking friends.
Oh yeah, they will oftentimes grab on the parts of their body that are uncomfortable.
Yes.
So if they're hitting their head a lot, or if they're grabbing their stomach, or if they're, how many kids I know that like mom will say, he just kept pulling on his ear, and they went to the doctor and like ear infection. So
Yes.
like so subtle. Or this is my favorite story, and then we'll be done. I had a little girl I worked with. She had trach. She had so much medical complexity. The sweetest, cutest thing ever. And non-speaking, we were working on a communication device, kept pointing to her leg. Just like would grab her leg, point to her leg. Not a whole lot of other things. Mom was like, something's off. Something's off. Went to get an x-ray. One leg was significantly longer than the other one.
Was she pointing to the longer leg or the shorter leg?
That I don't remember. But like, listen to them. They're communicating. And so, you know, I every time I work with a caregiver, I had one this week that like agitated. She's like, and the doctor was like, I think it's just GI. And she goes, something is off. And I was like, never have I worked with a mom, especially where her gut has said something is off and she's been wrong.
There was a episode on bowel sounds. Oh God. It was from last summer.
Where it's like, wasn't the GI Dr. Karen Margolis that was like when if a mom brought a child in concerns, like 93% of the time there was something going on.
Yes. Yes. And so follow the mom's intuition, follow the caregiver's intuition, because science is backing it up. That was a very empowering episode.
Yeah. We'll share that episode in the show notes.
Bless you. Yeah. Okay. Well, we have more episodes coming up. I know later this week I'm recording to Wisconsin speech therapists about the resources that they set up in their state. So that's exciting.
A lot of caregivers coming on.
Yep. And so we have more coming.
A lot of feeding stuff.
Yeah. We love feeding. But I have to run because my battery has died and Waffles ate the laptop charger.
Well, I have to teach for 2 more hours.
So you have fun teaching, and I'm going to hop off so that we don't lose this episode. But as always, find us on First Bite Podcast on Instagram. Hit us up on Facebook. And Waffle says she's happy to still be here. So, Erin, thanks, hon.